Good morning from Winnipeg. It is my privilege to introduce our first speaker, Dr. Leonard Valentino, who is the President and Chief Executive Officer of the National Hemophilia Foundation. But prior to that, he was a pediatric hematologist at Rush University Medical Center, where he was a professor of pediatrics, internal medicine, immunology, microbiology, and biochemistry, and the director of the Rush University Hemophilia and Thrombophilia Center. For more than 2 decades, he cared for children with a variety of common and rare bleeding disorders and those with hereditary thrombotic disorders, period. He is a very well-known scientist, both in the clinical research area and in basic science, where he had a laboratory investigating the molecular basis of joint disease in hemophilia patients. So without further ado, thank you, Len, for doing this for us. Welcome. We look forward to your talk.
Good morning, everybody, and thank you, Sarah. And I'd like to thank Wendy and the organizers of CODEROUGE for inviting me to present at this very important conference on this a topic which is very close to my heart, patient impact and outcomes of heavy menstrual bleeding. And I'd really like to focus on what the impact of the 2021 von Willebrand disease guidelines might be on patient empowerment. So I start with the mission of the National Hemophilia Foundation, and I think it's really important that you pay attention to the last line, which says enabling people and families to thrive. And really that's what a conference like this today and tomorrow is all about, enabling women who have bleeding disorders to thrive and live their fullest life. So I would like to begin by telling you what I'm going to tell you about. First, I think there's a problem. And I think we all know that there's a problem. And you heard from the patient testimonials that began this conference, there clearly still remains a problem. Why is there a problem? And we'll talk a bit about that. And what can we do to solve the problem moving forward? So I'm going to begin with a case study. This was a girl that I took care of in my clinical practice, as Dr. Israel said, at Rush University in Chicago. She was a 16-year-old who presented with heavy menstrual bleeding. Menarche was at age 12, and her menses occurred every month, lasting 10 to 13 days. The heaviest bleeding was on days 2 to 4. There was no family history of similar bleeding disorders. The patient had been seen several times in emergency rooms, as well as by her primary care physician on numerous occasions, and the heavy menstrual bleeding was essentially dismissed. She was finally referred to the hematology department by her pediatrician, who was new to the practice and was recently out of residency and happened to be one of our prior trainees. Upon seeing this girl, she recognized something was wrong and this patient needed to be evaluated. The patient's signs and symptoms of bleeding had previously been dismissed, as I said, until this young pediatrician saw her. So I put a few quotes from people that I've been involved with. And I'm sure that many of you can feel comfortable that these are quotes that either you've had or you've heard from your own patients. That, how oftentimes the symptoms have been dismissed, that people have thought, it's only a mild bleeding disorder. Women don't get hemophilia. They don't get bleeding disorders. When I was first diagnosed, you can see on the left-hand side, they wanted to put me in a plastic bubble. Don't touch her. She might bleed. And I think that these are things that we really need to move away from and help women be able to advocate more for themselves with their primary care providers, as well as emergency room doctors, and of course, hematologists. So what are the challenges that women with von Willebrand disease and heavy menstrual bleeding face? So my patient flooded over pads and tampons. She soiled her bed linens at home and her clothing at school, which was very anxiety-provoking for her. She was unable to participate in extracurricular activities during her menses. She developed iron deficiency anemia, which is very common in these young people. And she also had a history of bruising easily and had epistaxis early in her childhood. Well, Up to 20% of women with heavy menstrual bleeding may have a bleeding disorder. Now, heavy menstrual bleeding is a very common complaint if you talk to obstetrician and gynecologists. So how is somebody supposed to differentiate between heavy menstrual bleeding of other causes, such as fibroid tumors or other endocrine abnormalities or bleeding disorders? It's all about taking a careful history. And of course, we'll talk at the end about the bleeding assessment tools. But in a study of 102 women with von Willebrand disease, almost 95% reported heavy menstrual bleeding, compared with only 2/3 of women without von Willebrand disease. And on the right-hand side, you can see some of the morbidity that is associated with heavy menstrual bleeding. Reduced quality of life and adverse psychosocial effects, I think, are most prominent that we really need to begin to pay attention to, in addition to the pain that's associated with heavy menstrual bleeding during menstruation. Of course, there can be much more significant impacts, like unnecessary procedures. I actually cared for a woman who had had a hysterectomy at age 19 because of heavy menstrual bleeding, because the gynecologist had not done further investigation and wasn't sure how to manage the bleeding. So she took her uterus out. Of course, that solved the problem, but that's not the cure. So I think we need to think more about, what can we do? And heavy menstrual bleeding impacts both physical as well as mental aspects of health-related quality of life. There's iron deficiency, as I mentioned, but of course there's employment and educational consequences as well. We heard about my young girl who wasn't able to participate in her extracurricular activities. We've heard of women who have challenges with employment, being at work, being present when they're at work. And of course, the perceived impact of menstruation on overall life activities has found to be substantial. You can see some of those impacts on the right-hand bar graph. And this is from a sample of 22 women with von Willebrand disease. And during menstruation, you can see anxiety, impact on leisure activities and vacation planning. Not only the psychosocial effects, but certainly physical effects as well. So we know that heavy menstrual bleeding causes gynecological complications as well. Early hysterectomy or uterine ablation in undiagnosed patients. And undiagnosed patients with von Willebrand disease receive early hysterectomy or uterine ablation procedures at a significantly younger age than those other patients. 8% of hysterectomies are performed in undiagnosed patients before the age of 25. That's an amazing statistic. And I think that that's really an important thing that we need to be training our obstetricians about, is to be looking for bleeding disorders such as von Willebrand disease. Women with von Willebrand disease also have higher rates of pregnancy complications, bleeding following miscarriage, bleeding during pregnancy, and of course, postpartum hemorrhage impacting about a third of women, and severe postpartum hemorrhage in about 10%. And up to 30% of females have miscarriages due to bleeding disorders. When I first started in this field, this was a real challenge to get gynecologists to understand that a bleeding disorder workup was necessary for somebody who had recurrent pregnancy loss. They were only thinking about the thrombotic complications that could result in miscarriages. But we also were able to begin the work to educate the gynecologists about the impact of bleeding disorders also on recurrent miscarriage. So what about the delays in diagnosis? And I think this slide really emphasizes the importance that the time from first symptom until clinical recognition was 16 years. And the age at diagnosis in the middle, 33 years of age. Now that's an unnecessary delay in diagnosis. Now in the United States, the Department of Health and Human Services has something called Healthy People 2030. And these are initiatives, over 400 initiatives to improve the health of Americans. And one of those is that we should be diagnosing people with von Willebrand disease earlier in life, before age 21. So this is an important component of the work that we're doing to advocate for, to educate clinicians as well as people with potential bleeding disorders on the necessity to be looking for diseases like von Willebrand disease. The top specialties diagnosing von Willebrand disease, you can see on the left-hand side, almost a half are hospitalists. These are women who are entering the hospital for a bleeding disorder. These should be outpatient diagnoses. We need to better equip our primary care providers, as well as our hematologists, to be able to diagnose von Willebrand disease. On this slide, you can see the effects of menstruation on life activities. If you weren't convinced before, you can see here on the right-hand side that in the controls in this study, 3/4 had no limitations on activities or negative influence on lifestyle during menstruation. But look on the left. Look how impactful menstruation is for these women. Limitations in activities and negative effects on lifestyle in almost 1/4 of the women. But in the lighter purple, you can see no limitation on activities, but a negative effect on lifestyle in another 1/3. So this is a very significant impact on health quality of life. And we can see that 28% of women with von Willebrand disease felt as if their health and quality of life was fair or poor compared to about 11% of the controls. So we know that bleeding disorders, and in particular von Willebrand disease, impacts women's health-related quality of life. So who is making the diagnosis? You can see here in the table on the left, who's making the diagnosis in women. You can see about half are hospitalists or emergency room physicians. The hematologist is only making a diagnosis in 1 out of 5. This should be happening much earlier in the journey, and I'll show you that in a minute. Hematologists are entering the journey for these women very late. Primary care providers, about 15 to 20% of the time, are making a diagnosis. And again, I think it's unacceptable that obstetrician gynecologists are so poorly equipped to be able to make the diagnosis of von Willebrand disease. So here's the patient journey. And I wanted to begin because I think this is a fairly typical journey for women with von Willebrand disease. So a woman or a young girl, as my patient exemplified, will have bleeding. She'll frequently be seen in an emergency department where her bleeding symptoms are dismissed, minimized, or thought to be due to something else. The bleeding symptoms continue, and the patient continues on this path of morbidity. Again, accumulating the anxiety, the stress of heavy menstrual bleeding, or even the consequences of easy bruising. How often have we heard patients or family members telling us children were ridiculed because they were frequently bruising at school? They were outcast from peer groups because of bruising or nose bleeding. And I think that that's a real challenge for children to be fully participatory when they're at school, when they're having nose bleeding. What's the response? Send the child to the nurse's office. And the child then spends 1 or 2 hours in the nurse's office, not getting their lessons done, not being able to participate. So we need to do better. Even primary care physicians, as you can see on the lower left at the bottom, they're not equipped. They encounter these patients, but they don't do anything. They just, again, dismiss those symptoms. You can see there that there's another encounter with a primary care physician who finally does something. They do laboratory tests, but unfortunately, they're not equipped to be able to make the diagnosis and interpret those laboratory tests. They frequently order the tests, but then they don't know what to do with the results. The patient is then seen by a gynecologist. The gynecologist is equally incapable of assessing fully the symptoms, as we've seen previously. But again, the tests are ordered. The tests, again, are not appropriately interpreted frequently by both primary care physicians or gynecologists. That test results sit there really unacted upon, and the patient continues to have bleeding. They're finally seen by a hematologist. How they get to the hematologist, it's unclear whether it's referral from a primary care physician or a gynecologist or self-referral oftentimes. But the hematologist now encounters the patient, hopefully interprets the history, the family history, their personal and social history appropriately, and then looks at the prior laboratory tests for a clue, and then orders confirmatory tests. And now the patient is on the journey to a diagnosis. So we've had all of this morbidity. Finally, there's a diagnosis. There's a confirmatory set of tests that are performed. The patient receives treatment, and the bleeding is decreased. I think this is a fairly typical patient journey. We saw that women are in their 30s before they're frequently diagnosed, having multiple encounters with the healthcare system to no avail. So what happened with my patient? This adolescent was diagnosed by a hematologist, it happened to be me, with type 1 von Willebrand disease. She underwent a DDAVP challenge test, which demonstrated a very robust response. The patient continued to use DDAVP as needed. Her bleeding was successfully controlled, and she was able to resume her activities in school, as well as now participating in extracurricular activities. So I think the most important thing to recognize here is an accurate diagnosis resulted in appropriate treatment, and now not only patient, but family counseling. And it turned out that this patient's father also had symptoms of bleeding that were unmasked when we finally did a thorough history. So we can think about what are the opportunities for patient activation. I think one really important thing is we need to encourage self-identification using the self-BAT. And I really like what Dr. James has been doing in terms of promoting the self-BAT, which is a validated and tool found to yield reliable and effective screening results, particularly for women that are being assessed for von Willebrand disease. Women can do this themselves. The Let's Talk Period website, the Better You Know for the National Hemophilia Foundation, have these tools available. We're promoting this to people who are currently undiagnosed, who are at risk to have a bleeding disorder. Patient empowerment, I think, is also important. We've actually changed how we're referring to our patients. We're referring to our patients as subject matter experts. Who can be more expert on their disease than somebody who has the lived experience? We heard that from one of the patient testimonials. So we think that patient empowerment is important, and patient organizations such as the Canadian Hemophilia Society play an important role in disseminating and implementing guidelines and encouraging people to participate in their care, prioritizing educational materials to help empower patients. And we all need to be improving knowledge. Conferences like this, I think, are incredibly important to increase the awareness of online campaigns that are aimed at patients and seek to improve their knowledge of bleeding disorders. The Better You Know site, as well as Let's Talk Periods, are good examples of how we can improve the knowledge for women and girls and family members and men who love these women about the potential for bleeding disorders. So how can the international guidelines for von Willebrand disease benefit patients and healthcare professionals? I think there's still a number of questions that have to be answered. Will the availability of the guidelines impact clinical practice? How will the recommendations impact patient quality of life? What strategies can be used to disseminate the guidelines? I think this conference is a great example of that. Will the recommendations for prophylaxis impact the lives of people with von Willebrand disease, especially women? And how can patients be integrated into the guidelines and recommendations? So I think it's important that we all recognize there's many questions that remain to be answered. The guidelines are a first step, but we've got a lot of work to do to implement these guidelines. And most importantly, as you'll see on this slide, I think it's about education. It's educating clinicians, patients who have von Willebrand disease, and more importantly, those that are at risk for von Willebrand disease or other rare and ultra-rare bleeding disorders about the potential to have a bleeding disorder and promulgating the use of the self-BAT in these conditions. So education is incredibly important. But I also think that we need real-world data. We need to begin to collect information on the value of these guidelines, how important they are. So lastly, I'd like to summarize in the last few seconds that von Willebrand disease places a substantial burden on patients with a bleeding phenotype, being a major determinant of the impact on health-related quality of life. Women with von Willebrand disease report a variety of limitations in daily life, including mood changes that I think are particularly important. Patients will often visit the same specialist more than once. And the journey for a diagnosis of von Willebrand disease can be quite long. We need to shorten that. The management of von Willebrand disease can be complicated with wide variability in patient bleeding symptoms and differences in clinical practice. So we need more decision-making help for clinicians in this process. And I know that all of the organizations that work to develop the guidelines are working on decision aids to support clinicians and patients. And then finally, we need to disseminate the international guidelines as a priority that could involve translation into local languages, plain language summaries, and then, of course, communication via diverse methods, such as what we're doing today. So I'd like to thank all of you for your attention, and most of all, I'd like to thank the women who have empowered this type of a conference to really be so successful as it has been. So thank you very much. Dr. Israels, I'll turn it back to you.